report. A reminder that if you miss 2 or more consecutive meetings, that you will get contacted by Televis if you still would like to participate on these committees.
Hey, Dale, sorry, or Chief, this is Dan. Can you get closer to the mic? It's pretty vague. It's not nearly as good as it was for the State EMS Council.
All right, so I tell you what, we are going to go back to the other.
All right, let's do a repeat on the audio. Can you hear me better now, Dan?
Way better, thanks.
Okay, excellent. Back to good audio. Thank you. All right, so I will just do the reminder about the recording piece, which is that this meeting is being recorded. Everything said in the room or online is part of the permanent recording and posted to the department's website. In your packet, there is the attendance report. If you missed 2 or more consecutive meetings, you'll be contacted by the Bureau to ensure that you still would like to be a part of the committee. We have 2 vacancies on the committee. The first is a physician who specializes in severe acute head injury treatment or spinal cord care and who has demonstrated an interest or expertise in EMS. The second is emergency physician serving an EMS council Western region that is linked to the EMS council position. For those members who have a term that is expiring or interested in applying for a position, the application process is on the governor's website. The link to that is on the agenda packet as well. I will just very briefly cover our naloxone leave behind program to say that we have over 10% of our EMCTs in the state of Arizona trained in naloxone leave behind. We have 39 EMS agencies who are currently participating, and we have at least 318 kits that have been scanned and given out to community members throughout the state of Arizona. So a big thank you to everyone who is participating in that program, and thank you to Dave Hansen and his team for continuing to help bring EMS and their agencies into the program as well. Next, I will turn it over to Chief Garcia for a Bureau report.
Right, thank you and good afternoon. We have about 25 slides that we will include in your packet for today, but in the interest of time, we will not cover everything. We want to pause on EMS portal changes and let all of our medical directors and agencies know that there are some changes coming to both our EMS and hospital portals. If you log in, you will, as you interact with us, need to make sure that you are unblocking the email address that is shared here. It's an imagetrendlicense.com email address that we want to make sure that is not blocked by anybody's spam filter, so you can keep up to date on any correspondence through that portal. We're also going to be socializing that there's an opportunity for agencies to sync up their EMS portal on the licensing management side with AZ Peers Elite, and there are some big benefits to doing that and managing all your users in one place. So that will now be an option. And finally, over the next year, you will see that the state of Arizona and ADHS will be rebranding. We will be rolling out a new logo and a new color scheme. So if you start to see some correspondence or anything in the portal that changes from that red squared logo to the new logo, that's going to be that copper and turquoise color, just know that it is not spam. We are rebranding, and we will keep everyone updated on these EMS portal changes. So thank you for allowing me to go over that. Next, we'll do some quick legislative and rule updates. And skipping ahead to our rulemakings, if you go one more, on our ADHS website, we do provide updates on rule meetings and opportunities for public comment. We have a few rulemakings that are ongoing with information available on EMR training and paramedic endorsement, ground ambulance interfacility transport reporting, and also some links to healthcare institution rulemaking. For anybody that is interested, those are live links. They will take you to the website where you can see info on any notices that have been filed, and of course, any opportunities for public comment. I'm going to pause on the scope of practice for a minute, though, and Dr. Bradley, I don't know if you want to chime in here.
Sure. I just want to make a big thank you to this committee for all the work that went into updating the scope of practice. I know this committee came together with PMD for a special session in addition to the normal scheduled meetings and put quite a bit of time over several meetings into reviewing and updating the scope of practice for EMR through the critical care endorsement. That approved scope of practice that went through MDC has now gone through the finalized approval process. It has been approved and will now go live January 1st, 2025. So a big thank you to everyone. We will work on getting that out in a format so that people understand while the actual critical care endorsement does not go live until January 1st. We recognize that we have heard from training programs and EMS medical directors that they would like some time to actually see the finalized and approved scope of practice and drug table so that they can start training and getting people ready to go live with us in January. So we will put together something that will go out via Gov Delivery. So we are committed to get this information out in front of everyone, but just are cautious to say this does not actually go live until January 1st. However, we want to make it available for agencies and medical directors who would like to begin training on this new standard. So
This is really tremendous. I just want to again thank the commission, like Dr. Bradley said. Part of what we will be communicating and socializing in the coming months is the fact that because of the Medical Direction Commission and the work of so many stakeholders and the rule writers here at the state, we now have a new critical care career pathway in EMS, or will have that in January. And so we absolutely will be sharing some information on what that career pathway looks like and getting that out to all of you. So thank you. And if we go on to our next slides, we'll just preview this so that the MDC does know what is in this packet. There's some info on new rules, and you can go quickly through those slides, Shelley. Resources have been updated on our website, including our new statutes and rules book that was most recently refreshed this week. That link will take you right to it. We have additional state and federal updates that we won't spend much time on today because that was covered during our EMS council meeting. But if you go ahead to our one more, I think it is, EMS and trauma system strategic planning slide. I know some of you in the room and on the line were already in our EMS council meeting that reviewed our 5-year strategic plan. We again want to acknowledge and thank all the participants in the development of that plan that was reviewed and approved today by EMS Council. There is still an opportunity to look at that draft plan and still an opportunity to provide comments until the end of the week if anyone from the commission would like to do so. But we really appreciate all the work of the stakeholders helping us to pull that together. And I think that should probably take us to the end of our updates, unless Dr. Bradley or Julia would like to highlight anything else in this packet.
good. Thank you.
Okay, end of report.
All right. Thank you, Chief Garcia. And just so we can capture your attendance for the meeting record as well, I see Dr. Foster. If you could just come off mute and let us, and that we can capture your attendance, please. We do see you online, so if you have a chance at any point, just raise your hand and we will call on you and get your attendance recorded for the meeting today. Thank you. Next for standing committee reports. First, Dr. Augenstein for a TEPI update.
Yeah, Carissa shared that an issue with ESO or ESO came up and that they're changing products to finish out their contracted term for the trauma database. The announcement of the RFP bid winner for the next trauma database contract is still pending bid review processing. The minutes were approved as presented. CON checklist displayed for resources for stakeholders. We voted to approve updated criteria for cardiac receiving and referral centers in addition to reducing the CEDAR data collection fields. Rachel gave background on EMS and trauma data available publicly, and there was discussion for county-specific data requests. And then lastly, heat-related illness data dashboards were discussed. And that's it for me.
Thank you. Next, Dr. Johnson for Education Committee.
Brief. We went ahead and approved the CPR training. We'll plan to revisit that next year with the shared data. We also voted to approve a joint committee with the PACES to update the sleep state training. And then we also voted to approve a work group for TSA training, and we'll be meeting in October to develop that training. And then Dan, we discussed some of the new skills testing in Arizona, and we went over some of the new things with the scope rules that will become effective in January. And then finally, a representative from the Red Cross came in and talked a little bit about their new neonatal advanced life support training.
Thank you. And next, Dr. Gaither for PMD update.
Absolutely. Thank you, Dr. Bradley. Almost all of our topics are going to be covered later here today, so that's going to make this report easy. We, of course, reviewed and approved the meeting minutes from the March meeting, as well as the May special session meeting. Dr. Bradley did share some updated information and guidance on obstetrical emergencies, specifically preeclampsia and gestational hypertension, and recognizing and initiating treatment of that in the field. The other items, we're going to discuss two of them today. That is Table 1, which was approved, and we will discuss at length here, in addition to Table 3, which was also approved by PMD, and we will discuss later today. The final item that we talked about was looking at the schedule for making changes to the drug tables. There was extensive discussion about when we should make those updates, and the group recommended that we make changes annually to that table so that there are not multiple changes throughout the year that people have to keep track of. That's it from PMD. Thank you.
Thank you. And next, Aubriana for PACES update.
Okay, so for the PACES Council, in July, we approved the March minutes as presented. We also voted to approve amending the bylaws to add a mission statement. The EMSC team provided information on the EMS for Children program. Our community partner, Ann Stafford from the Arizona chapter of the American Academy of Pediatrics, presented on the Pediatric Emergency Care program. And then we also had our community partner from the Western Regional Alliance for Pediatric Emergency Management, Christopher McCarthy, present on pediatric program products and resources available for EMS and hospital providers. We voted to approve the Arizona EMS for Children, Making Arizona Ready for Kids program. This is a pre-hospital pediatric recognition program. In addition to this, DHS Representative Antonio Hernandez presented on pediatric drowning data, which will continue ongoing conversation throughout the year. And then lastly, Chris Gilbert solicited volunteers for the joint work group with the Education Committee on updating safe sleep materials on September 26th.
Thank you. All right, next, if we can get a motion to discuss and amend and approve the meeting minutes from the May 16th special session, or regular session, I should say. Thank you, Jason. Can I get a second? Thank you. All right, as we scroll through those, are there any recommended amendments to the meeting minutes? Pardon? All right, hearing no recommended amendments. Anyone opposed, please say nay. Any abstentions? All those in favor say aye. And online, we have 2 members in the room, so we will need some online members to vote, please. You can do a hands up or a off mic vote. Aye. Thank you.
Aye.
All right. Okay. Next, if we can get a motion to discuss, amend, and approve updates to Drug Table 1, the EMCT drug box. All right, so I see first from Dr. Johnson, second from Dr. Godzenker. So I just wanted to give a little update to this committee. I know many of you participated in PMD either as committee members or just as participants in the room, as we had quite a bit of discussion and looking at these drug tables. So just to remind the committee of how we kind of went back and forth in making these updates, we had brought forward we had the joint special session of PMD and MDC together. And after doing the huge update on scope of practice, at the end of that 4-hour meeting, tried to also start addressing the drug tables and realized that we were probably had outdone where our brains were really ready to go at that point. So we tabled that and then really brought this back to MDC. And then between the last MDC session and PMD, kind of try to reassess and look and see what would be the best way to present this information. How do we make this easy for EMS agencies to implement this, recognizing that critical care paramedics are a very small subset that will have a much higher standard educationally, much higher standard for recertification in addition to initial certification. And on top of that, when we look at the oversight from medical direction, this is very different from your normal typical paramedic. And so with that information, as well as information from multiple air medical providers who utilize critical care paramedics and critical care services across the state, they were quite helpful, provided at the Bureau their guidelines, their drug tables, and we were able to really come up with, I think, a good consensus. So I wanted to give a little bit of background of how we went, kind of what was initially presented back in May to where we are, what PMD's work at the meeting earlier this year. So a big thank you to all the PMD members for working on this and producing this. So I will, with that preamble, we will kind of slowly go through this. You will see highlight, if you scroll down to the middle of the page, we have added IV or intravenous formulation. So to make sure that we have that appropriately on here. And you will see new columns here. So if you can go to the column title. So as you can see here, we've added EMR. There are not many medications on there for EMR, but there is an option. So we wanted to add that to the column. And then we also added the column for critical care endorsement to the paramedic. And so this was one of the things that we recognized was going to be probably the easiest way to layer on this subset of highly trained paramedics and the expertise and the training that they would bring in and what medications they would be allowed to use. So that is why we kind of expanded the columns on this. So as you scroll down here, you can see this is a new addition to Table 1, which is the addition of antibiotics as an optional agent specific to critical care paramedics. So that's the first one that you see on page 1. When you go to page 2, the next one was also another optional agent, which is blood products. One of the things we recognized was updating some of the terminology to also match with scope of practice. This is an optional agent, again, for paramedics with a critical care endorsement specifically. The next thing, if you scroll down, you'll see Crotalid or Anavip. So we made sure we have the generic name. This is optional. This, we got feedback from some of our air medical providers that this is something that they use, especially in more rural parts of the state. So again, specific to the critical care endorsement paramedic. One just minor edit that you can see, Cyanokit was taken off because we recognized we had the brand name on, so we just moved it down alphabetically. So it's not that we're removing that. I just wanted to clarify that piece. We just have the generic form lower on the agenda. You can see under dextrose, 5% in water. That was on there as an EMT optional agent before. We had feedback from the committee that this should be listed, that this should not be under the EMT column and should start at the AEMT level and above. Another additional as an optional agent was droperidol or haloperidol as an optional, again, for critical care paramedics only. If we go to scroll to page 3, this is where the committee will remember we had quite a bit of conversation back and forth regarding different hypertension medications. And one of the things that really, in kind of thinking back on the discussion, the recognition came out that there are certain medical directors that feel very strongly in their practice they use one specific medication. Another medical director may not like or feel comfortable with that medication and use another one. But really, when we look at the subset of critical care paramedics, that paramedic is going to work under the guidelines of that medical director. And so we wanted to make sure that there was the option to have these agents on there, recognizing there are conditions within the state and parts of the state where this would be beneficial for those critical care trained paramedics. And so the best option that PMD came up with, which I think is a really nice compromise, is not a list of just a broad category of beta blockers or antihypertensive medications, but rather listing out the most common ones that we see in EMS guidelines, both in the SEMSO model EMS clinical guidelines, as well as the existing critical care air medical programs throughout the state, and then list each individually with the optional category for critical care paramedics. So you will see that was the addition of esmolol, as well as hydralazine, and I'll skip a couple, labetalol, as well as metoprolol and nicardipine. So as you can see layered onto this table is that each one of these is optional, and it's really up to that medical director, and it's specific to their guidelines to determine if they would like to implement those. There was a request for hydromorphone, again, as specific for critical care paramedics. The hydroxycobalamin, you can see the middle of the page there, that is the generic for Cyanokit. So just a reminder that we just fixed that one typographical issue. And then we have the generic for Keppra, and that is also optional. And then we get into some other medications, so such as mannitol. And then if you go onto the last page, you will see also hypertonic saline, 3% saline. Some medical directors utilize one versus the other for this subset of patients. And so we wanted to make sure both of those were available as an option for those critical care paramedics. And then you also see here the nitroglycerin IV, phenylephrine IV, and vasopressin as those options for those groups. One of the things you recognize here is thrombolytics. This is, again, specific to critical care paramedics as an optional agent. So this is kind of a culmination of all the work of the meetings that have been had. So I will kind of stop there and then open it up to any comments or questions from the group. Yes, Dr. Rice?
Yeah, I just wanted to say thank you to Gail for spending so much time trying to put this together. I think that it looks very comprehensive, and I think that the Bureau and this committee have taken a lot of time to be very considerate of both national guidelines and what's being used in current practice now. So just wanted to throw my support in and say that I think this looks great.
Thank you, Amber. Dr. Gaither?
Thanks, Dr. Bradley. Likewise, congratulations on a lot of work. This is a huge amount of changes. Overall, I think they're very well done. I think I was going to comment kind of separately on each column changes. Obviously, the EMR is very straightforward. I support completely. I wanted to speak in favor of removing the D5. That just causes confusion in our EMTs about what they can use to resuscitate patients with dehydration. So support removing that from the EMT column there. And then similarly echo, I think what was Amber's thoughts. I support kind of the carte blanche approval of the critical care paramedic scope of practice, or drug box contents, I should say. I think the key that really I would hit on is expanded training, expanded medical director involvement. These tend to be paramedics and systems that have very active and very involved medical directors, which do allow us to have a lot different philosophical approach to contents in this drug box, including more options, really catering to the highest performing paramedics in our system and allowing them to practice at an expanded scope. So it's a long-winded approach to say I'm in favor of all the changes proposed here.
Thank you, Josh. And I just realized I was remiss in not pointing out on page 2 and 3, there are 2 additions for the EMR that are not highlighted. We had the epinephrine auto injector, so that would be for an EMR. So again, this would be specific to the auto injector, and then also naloxone for a pre-filled atomizer or auto injector. So I wanted to make sure that that was recognized. Those are the only 2 medications that are being proposed as additional options for EMR level. So those were not highlighted, but those are both on here.
Looking for a motion to accept the table.
I think we do have a motion on the table, so
We'll take it.
yeah, but we'll take another one. Thank you.
Hey, Gail?
Yes, Dan? Yes, go ahead.
Yeah, this is Dan. I'm in favor of this, and I echo what's been said about how much work. I mean, my goodness, the number of permutations of the way this stuff can be shown, kind of mind-boggling. Whatever they're paying you at the DHS, they should double it. Let me know if you need a motion for that. But in any case, it's worth reminding ourselves. So this is as you know, there's the role I've played for decades at this level. We're doing this really not evidence-based. We're doing this responsive to an entire arena of practice and medications and so forth that have become the way we do things. And so that's one comment, is just to remember there's a whole bunch of this stuff that we're not even sure in the critical care setting or the ED how much some of these meds make a difference versus others. So it's just worth us remembering that. And this, again, this isn't a is not a speech against the what we're going to do. But the other thing is the this is permissive, and so having been a medical director for a really long time and having been an air medical director for 18 years, the assumption that everybody that's doing critical care and everybody that's in the air business, last time I heard we had like 100 air medical ambulances licensed in the state. The assumption that those all have high level, incredibly engaged, well-trained, focused, and involved medical directors, it's, in my opinion, historically, it's a fallacy. So I think it's worth us remembering that once we make this permission, and anybody who raises their hands, especially because in air medical, it's functionally not regulated. Anybody can do it. And I know the people who've been involved in this are the ones who put a huge amount of their time and undoubtedly way beyond what they're paid to do as a medical director. But I'm always the one who wants to bring up, we're now permitting anybody who basically is a licensed physician in the state of Arizona to be in charge of people that are doing this stuff. So, but having said all that, I'm really grateful for all the work, and I think it's going to pass, and I'll support it.
Thank you, Dan. I think those are good points. And, one of the things that is useful is that previously the drug tables were under rule. And so we had to actually get rule to be open to make any changes to the drug tables. So we are fortunate now that we are able to do that through the committee structure with the approval from the director's office. So that has been a very fortunate change in the last several years, so that we can adapt if we see that there are any adverse events or issues that need to be changed in relation to this. So I think that is a good point made, and appreciate your insight.
And one more question: in the extensive conversations, did it come up that there's no question that the medics that I worked with for 18 years, it was unbelievable what they could do. But in that setting, it was essentially always a nurse paramedic team. And I think both nurses and paramedics came to highly regard what each of them brought to the team. And so the interesting thing about this is this now means you can go to medic. There will be financial reasons to drop the nurse, etc. Was any of that conversed? Again, it's not it's just a fact now, where historically, basically the very, very broad Nurse Practice Act in the state of Arizona was used, and the paramedic would come along, be incredibly helpful, learn a lot of stuff, and certainly are prepared to be what the country now has as critical care paramedics. But did that come up? This is an interesting wrinkle that might change the team, where I always found value. Well, I'll say it this way. Nurses saved my tail in the emergency department hundreds of times, because they're way better than a doctor at a lot of things, especially when it comes to patient safety and paying attention. Did that come up during the conversation? Amber might know, or Josh too.
At the PMD meeting, no, that specific conversation was not had. I know that there are updates to the critical care as part of the whole critical care rules update. There is a update to the staffing criteria. I don't know the specifics to that off the top of my head to quote that directly. So that was not covered specifically at PMD. Yes.
Thanks. I appreciate that.
Under their ambulance rule for the staffing bill, I think an RN is required as part of the criteria. I think the table will change. So I'm going to replace that, or maybe not. Maybe I'm wrong. Maybe it does.
We can continue to review rule if there are questions about the staffing models, but both air and ground have staffing requirements with respect to billing and scope of practice.
Josh, I see your hand up.
Thanks, Dr. Bradley. I couldn't hear what was discussed in the room, so my apologies if I'm repeating something. I do think it's worth mentioning, Dan, that A lot of this is truly driven by our staffing shortages. I think it's important to note that even in urban environments, patients can wait for days. I'll say that again, days for a critical care transport with a nurse. We simply just don't have enough people. This really does allow us to provide that particularly ground level of care, ground transport level of care with a critical care paramedic that gets a patient to the right place in a timely fashion. I think it's an important point to mention.
Thank you, Josh. All right. Is there any further? Oh, yes.
I was just gonna say that in statute, it does say for critical care interfacility transport, the staffing does require a nurse, a physician or a registered nurse.
Okay. Thank you very much, Matt. All right. There you go, Dan. So thank you for air specific. Okay. Thank you. All right. Any further discussion regarding table 1? All right. Hearing none. Anyone opposed to table 1 as updated? Please say nay. Any abstentions? All those in favor say aye.
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 I,
All right.
Aye.
And again, just a reminder for those online, this is only for appointed members to vote. Thank you. Table 1 passes. Thank you very much.
We'll next go to the director of legislation, and I think it'll be January 1st.
Correct, yes. Shelley made a good clarification point. Similar to scope of practice, this will go into effect on January 1st. We do plan on sharing these in a format that individuals, medical directors, and agencies can start training to the standard with the understanding that this will not go live until January 1st, but we wanted to make sure that this was available for people to start their training for that. All right, we are next going to move to table 3. If I can get a motion to discuss, amend, and approve update to drug table 3. All right, thank you. I know Dr. Johnson is going to be jumping online virtually with us in a second. All right, so we have a motion and a second. Thank you. Just to give a little bit of update as well regarding this drug table. So a little bit of history as to how we got to this table, and then also the discussion that was had at PMD that was quite robust. Historically, table 3 was specific to interfacility transport agents only. A few years ago, there was a pilot that was proposed for a hospital at home program. And as part of that program, we had a request at the department to add additional medications. So the committees took that into account and went through and recognized that other facilities were also utilizing paramedics in the hospital setting. And that resulted in table 3 being created into table 3A, which was interfacility, and table 3B, which was for medications being administered within a hospital setting. This was also done during COVID, where we had a significant nursing shortage, and that was part of the discussion at the time of how paramedics were being utilized to help fill that gap. As part of the conversation that was had at PMD was, at the time, we did not have a critical care endorsement in the state, nor did we have approval to be able to add that. So this was something that we recognized the committees had added medications that probably were more appropriate for a critical care paramedic, but that endorsement was not an option in the state of Arizona at that time. So with that conversation, PMD had a pretty robust discussion with conversations about equity in regards to training and experience for a paramedic that's in an ED versus a paramedic that has gone through a critical care program and is now a critical care endorsement within the state of Arizona. As a result of that, you will see the addition of the critical care paramedic endorsement added to the tables. The key thing, there is really very minor changes to 3A. You can see there that anything that was available for a paramedic is available for a critical care paramedic. We did clarify that blood was updated to read as blood products. That was the only change, I believe, made to table 3A. If you go to table 3B, that is where there was quite a bit of robust conversation with the addition of some medications, as well as removing the ability of a typical paramedic in the ED to administer medications and converting that ability over to a critical care endorsed paramedic. And so that was the conversation that was had and approved at PMD. As you can see here with antibiotics, there was an ask to include different routes of administration. That has not been something that we have historically done, but it really was an ask from a number of hospitals to say they have paramedics, that they would like the ability for a paramedic to be able to give an oral antibiotic or an IM antibiotic if trained. And so that is why that was added. We again clarified blood products and made this specific to a critical care endorsed paramedic, with the recognition that there is quite a bit of training that does need to go into place with administering blood products. Dicyclomine was another request from the hospital programs, and that was added. You can see that dobutamine was converted to a critical care endorsement. If you go down and look at phosphatonin, again, converted to critical care endorsement. Heparin converted to a critical care endorsement. We did add hydrocodone, oral pain medication, as an option for paramedics in the ED as requested for both. Insulin infusion pump and insulin subcutaneous were both converted to the critical care endorsed paramedic. And then we added ketorolac or Toradol, and this is an option for both regular paramedics as well as critical care endorsed paramedics. Labetalol and Keppra were both converted to the critical care endorsement. We have added meclizine for both regular paramedic as well as the critical care endorsement as well. If you go to page 5, you can see the addition of Reglan for both hospital and critical care endorsement. Metoprolol IV was converted to critical care endorsement. And then you see moving further down, oxycodone was for oral pain medication added for both regular paramedic as well as critical care endorsement. Potassium oral salts and prednisone, so 2 oral medications added both for regular paramedics as well as critical care endorsement. Sucrose as well as topical anesthetics such as Emla, Let, and LMX. This was a request from many facilities who use these, especially in the pediatric population. And so that was added for regular paramedics and critical care endorsement. And oral vitamins also converted specifically to both of those. So as you can see here, we've really tried to give more options for oral medications for paramedics working in the ED to be able to administer, and have converted over many of those more advanced medications with associated risks and additional training that is required to administer those. PMD is making the recommendation to convert those over to the critical care endorsement paramedic. So that is kind of the culmination of the changes being proposed from PMD to this group. Yes, Dr. Gaither?
Dr. Bradley, you may have hit on it already, and I'm post night shift, so I'm sleepy. I apologize. Can you go back and just define for me, at least, a hospital paramedic? Are they limited to practicing under the direct order of a physician for the purposes of this table?
Yes. So any paramedic working anywhere has to function under our typical rules of medical direction oversight.
Maybe I'll clarify again. I'm tired, so I don't speak as clearly. My understanding is that for those agents listed with the abbreviation HA, those must be administered in a hospital or a hospital at home program with a direct order from a physician or a licensed independent provider.
Correct. Yes. As long as that provider meets our definition outlined in rule, correct.
Perfect. So again, just to highlight it for the group, I think one of the very important factors we discussed at PMD for this was that we'll use the one here. If a patient is going to get Reglan, metoclopramide, there would be an order from a physician to give 10 milligrams of Reglan for this patient at this time. These would not traditionally be standing orders or guidelines as we're used to for our traditional paramedic scope of practice.
Yes. Thank you, Josh. You have a comment, Brian? Brian's thinking across the room. I'm trying to figure out if I have to stand and walk. I'm just going to walk his way and see if I don't need to. See if he comes up with something.
So I guess my question is about this definition of a physician who can give these orders, because technically that person should have to meet the criteria to be an online physician. So if a paramedic was working in a hospital or a hospital that was not a base hospital, and they had ED physicians working in there who didn't meet the criteria to be online medical directors, they technically can't take an order from them. It's not just anybody that's a physician and an ED out there, right?
Correct. So it still has to be under our current rule.
Right, an online physician would qualify for that, but they're really the only ones that would then be able to order. They couldn't just go to the hospital and order from another physician.
Correct.
Right.
Yes. Dr. Castro-Morin, you can go ahead.
So then to further clarify, because I heard Dr. Gaither phrase it a couple different ways. And so, for example, a PA or a nurse practitioner seeing a patient independently from the ED physician in an ED, would their orders not be, would those orders not meet the state criteria for a hospital paramedic to fulfill?
Yes, you have there's sorry, I don't can be on mute. So correct, you cannot get orders from a PA or nurse practitioner. So you would have to get orders from a physician. So there's different ways that you could operationalize this in your facility, whether it be standing orders that a physician signs off on, underneath with a PA or NP working underneath a physician. But the rules are the rules. So the medical direction rules, we do not have open to make any adjustments to. So that is not open for us to adjust. This is really for us to create the drug tables to allow the medications to be administered.
Dr. Bradley, for housekeeping, I think I should add IM and P.
Okay, and thank you. As Shelley is pointing out for housekeeping purposes, to add the definition for IM and PO to this as well. So we do have a substantive policy statement on paramedics working in the hospital setting. So that is available on the Bureau's website, and we can certainly share that and make that available if anyone would like to see that as well. Any further discussion regarding table 3A and 3B? There is the recommendation from Shelley, which we have the note highlighted that we will add the definitions for the abbreviations IM and PO for consistency. So that is outlined on here.
Motion to accept tables 3A, 3B with what Shelley was adding for the.
All right. Thank you, Eve. Can I get a second, please? It'll have to be someone online.
Second.
Thank you, Julie.
Foster, second.
Thank you, Dr. Foster. All right. Is there any further discussion? Hearing none. Any opposed, please say nay. Any abstentions? All those in favor, please say aye.
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 Thank you. I do see your question in the chat, Sarah. Where can we view the changes before they take effect? We will make these available once they all are approved. We will send out hopefully sometime in October, both the combination of scope of practice as well as the updated drug tables to facilitate training and education. Just keep in mind, these will not go into effect until January 1st. So any communication that goes out will be very clear. We don't want anyone thinking that this is something that they can implement now, but we have heard loudly and clearly from many stakeholders the ask to make these available in terms of training. So that motion has passed. A big thank you to this committee and as well as PMD for their work on that. All right. I think that is the last of our action items. So any agenda items to be considered for the next meeting? Hearing none, call to the public. All right, hearing none. Upcoming events, I do want to point out there's the EMS-based hospital medical directions seminar that is October 18th in Flagstaff. That is both in person and virtual. A big plug for the medical directors. We have had some meetings with the DEA. They are going to be presenting there. They are very interested in talking to EMS medical directors as well as base hospitals. So if you're able to participate in that, I think that it will be very useful. So just want to make sure that goes out. We do understand it sounds like there's another conference that day as well. Unfortunately, it's always hard to avoid all other conflicts, but I think that will be a great seminar. Yes, Dr. Gamer?
Is there an online?
Yes. Yep, there sure will be. Absolutely. All right. Our next meeting is January 30th. Just to point out, this is not going to be on our normal meeting cadence. So for 2025, we have adjusted the dates of some of our meetings. So this will be January 30th as opposed to the normal third Thursday. So just be aware for the 3 meetings in 2025, please check your calendar. The meeting schedule is linked on the agenda as well, so you can double check that you have the time off. A big thank you again to everyone who participated in this process, and if I can get a motion to adjourn. All right. Thank you, everyone.